What's up, Ninja Nerds? In this video today, we're going to be talking about calcium disorders. Again, this is a part of our clinical medicine section. If you guys like these videos, they make sense, they help you, please support us. You can do that by hitting the like button, commenting down in the comment section, or subscribing. Also, check out the link down in our description box below. That'll take you to our website. On our website, we have a lot of amazing sources that we can help you out with, such as notes, illustrations, quiz questions. Go check that out, and I think you're going to learn a lot. All right, let's talk a little bit about calcium disorders, beginning our discussion with hypocalcemia. All right, so let's begin our discussion with hypocalcemia, discussing the pathophysiology. The reason why this is super crucial is because it helps to build a foundation to understand the causes, but not just that. I thoroughly believe that the understanding of the pathophysiology plays a massive, massive role in the diagnosis of different types of causes of hypocalcemia. So let's really dig into this a little bit. It's important to remember that hypocalcemia is controlled via what's called PTH. That's parathyroid hormone, right? We know that the parathyroid hormone is released, right, from these little glands on the back of the thyroid gland, called your parathyroid glands. So they're responsible for making this hormone referred to as PTH. Now, let's say for whatever reason, and we'll discuss those reasons in a second, the parathyroid gland is not producing an adequate amount of PTH. If it doesn't produce an adequate amount of PTH, what's going to happen? That's a great question. Well, one of the things that's going to happen is it's not going to work on the osteoclast. You know the bone tissue? If we were to zoom in on the bone tissue, you have these bone cells. And these bone cells, there's different types: osteoblasts, osteoclasts, osteocytes. Osteoclasts are going to be the big one. Now, osteoclasts, what's important with these is that they have different receptors for PTH. When PTH is actually low, what actually happens is it affects the osteoblasts, and those osteoblasts then communicate with the osteoclasts. If there's low PTH, what it does is it tells the osteoclast, hey, don't do anything. Don't resorb any bone. Don't break down any bone. So that's officially what's going to happen, is it's going to shut down or inhibit the osteoclasts. If you inhibit the osteoclasts, they won't chew away the actual bone tissue and liberate calcium into the bloodstream. So as an effect here, what's going to happen to the amount of calcium that gets into the bloodstream? It's going to be lower. So there's going to be decreased calcium due to less liberation of calcium from the bone. So there's going to be a decrease in what we refer to as bone resorption. So if there is a decrease in bone resorption, that means that we're going to break down less bone. This process will not occur, and we won't liberate calcium into the bloodstream. That's one of the reasons for hypocalcemia. The other concept is, what if PTH also is low? There'll be less ability to interact with the kidneys. Now, you know in the kidneys, there's different receptors for PTH, especially on the distal convoluted tubular cells, as well as on the proximal convoluted tubular cells. On the distal convoluted tubular cells, PTH is really, really important, because what it helps to do is it helps to increase the expression of channels that help to reabsorb calcium and excrete phosphate. If there's less PTH, will you be able to, and this is actually should be a blue arrow here, a dark blue arrow here. So if you have less PTH, will you be able to increase the expression of the calcium channels and the phosphate channels? No. So what happens is less calcium gets reabsorbed and less phosphates get excreted. So now as a result here, look what happens. You're gonna have less calcium and less phosphate. If I inhibit this process, what happens is that calcium gets lost into the urine and it doesn't get reabsorbed. The end result here is that I'm going to lose the calcium from being reabsorbed. And I'm also not going to excrete my phosphates. And so another little side result here, if you want to, is a little kind of like side off effect here, is that this can slightly increase the phosphates in the bloodstream. But the profound effect here is that you're not going to be reabsorbing calcium. So there is what we say, a decrease in calcium reabsorption at the kidney. All right. So that's one really big effect there as well. So decreased calcium reabsorption at the kidneys leads to hypocalcemia. Decreased bone resorption leads to hypocalcemia. The next component here is that PTH also acts on another part of the kidney, but I don't want to clutter the diagram here. So it acts at the DCT. It also acts at the PCT. So for simplicity's sake, let's come over here and look what happens. The PTH comes over here to the kidneys, right? Acts on the proximal convoluted tubule, which will be right here. And what it does is, it's supposed to increase the expression of an enzyme inside the cell. You know what it's called? It's called alpha-1 hydroxylase. Now, That alpha-1 hydroxylase is actually a really important enzyme. And the reason why that's an important enzyme is it helps in a very specific biochemical process. You know, there's a vitamin, it's called vitamin D, and it comes in different forms, but the one that we ingest oftentimes can be 25, or the form that comes from the skin, eventually gets converted to what's called 25-hydroxy vitamin D. And what we want, the effective, the active form of vitamin D, we want to be what's called 1,25. I'm going to abbreviate that dihydroxy vitamin D. Now, in order for this process to occur, I need to add a hydroxyl group on the one carbon. Guess who does that? This guy. Now, he's supposed to help this process. If I have less of him, am I going to express as much of him? No. And so if I don't express as much of this enzyme, is this process going to occur? This process will not occur. I will not convert him into him, so I'll get less of this guy. Why is that a problem? Reason why that's a problem is he comes down here to the good old GIT and increases the expression of the good old calcium channels. And if you're supposed to express calcium channels and you don't have them, guess what you're not going to do, my friends? You're not going to absorb calcium. And so in that process, you're going to have inhibition and you're going to have decreased calcium. And what's the reason why you're going to have a decreased calcium? Because of decreased calcium absorption. This will be because of decreased calcium absorption at the GIT. So decreased calcium absorption at the GIT is the reason for this process. Now, here's what I want you to see. If the body's not making PTH, this is how we end up with hypocalcemia. The same effect occurs because guess what? PTH, it goes and acts on specific receptors on the bones, on the distal convoluted tubules, on the proximal convoluted tubules. And so if PTH is normal, but it binds onto the receptors and the receptors are dysfunctional, it's going to precipitate the same effect. We'll talk later about what diseases cause low PTH and a receptor resistance at the receptor site. All right, what's another reason for patients developing hypocalcemia? Well, one is low vitamin D. Now, vitamin D is important because we ingest vitamin D, right, in different types of food sources and supplements, and so that should be absorbed across your GIT. Also, in normal sun exposure, we should be able to absorb vitamin D into the bloodstream. Either way, usually that form of vitamin D is what we refer to as like a inactive, sometimes we call it cholecalciferol, right? So we're going to represent that as CCF. That cholecalciferol, which is kind of like a very, very inactive form of vitamin D, should then move through the bloodstream where it reaches the liver. The liver is then supposed to say, okay, I'm going to then convert this cholecalciferol into what's called 25-hydroxy vitamin D. Oh, that sounds familiar. This is the one who does that. So he's going to then convert this into what's called 25-hydroxy vitamin D. Now, from here, the 25-hydroxy vitamin D is supposed to go to the kidneys. What's the reason why? I already told you why. Because it has an enzyme, the 1-alpha hydroxylase, that the PTH controls. And so from here, it should then be easily converted into what's called 1,25 dihydroxy vitamin D. Now, if we have decreased vitamin D, and we'll talk about the reasons why, maybe because there's a problem here at this site with the intake or with the sun exposure, or there's a problem with the liver where it can't convert that into the 25-hydroxy vitamin D, or there's a problem with the kidneys not being able to activate the vitamin D. Either way, if it's a absorption problem, a sunlight exposure problem, a liver disease problem, or a kidney disease problem, all of these can result in this. What's the issue with this? Well, let's just kind of save some space. Decreased calcium absorption in the GIT. That's going to lead to hypocalcemia. So we see this, we understand this now. That's not too bad. Let's come down to the last reason. The last reason is kind of interesting, and this is oftentimes, we can kind of break this into acute and chronic, and we'll talk about that. There's different types of, let's say, molecules in the bloodstream that we have present that are negatively charged, all right? Oftentimes, the big ones that I want you to remember are going to be what's called phosphates, all right? We'll represent it with this one. This one we can say sometimes what's called citrate. And we'll make this one fatty acids. Now naturally, these have negative charges on them. Now, what is calcium? It's positively charged. If you have negative charges, what if for some reason, right, you develop a disease process? And in that disease process, you end up with an increase in all of these, right? So now I have an increase in phosphate. I have an increase in citrate, and I have an increase in the fatty acids. If I increase all of these for whatever reason, and we'll talk about those reasons, why is that a big, big deal? Well, calcium exists in two forms in our bloodstream. It exists in a free form and a bound form. The problem with hypocalcemia is disease processes occur when you lower the free or ionized calcium. Well, guess what? If I have a lot of these, maybe I only have a couple of these, and so they only bind a little bit of the calcium. All of a sudden, I end up with a ton of these with a bunch of negative charges. This is like trying to be able to see, oh, baby, this calcium's gonna be like, oh, I see lots of negative charges over here. I'm gonna go over here and bind to one of these, and that calcium will do that. So what will happen is you have so many negative charges, and what they're going to do is they're going to bind the calcium. And when they bind up the calcium, they lower the free calcium. And that is what's going to lead to hypocalcemia. Now we'll talk about this a little bit more, and the reason why is some diseases, and most of them I should say, acutely cause this rise. And so oftentimes phosphates can be built up in acute processes, citrate acute processes, and fatty acids in acute processes. There's only one disease that chronically causes rises in phosphate levels, and we'll talk about that. Oftentimes it's CKD. So we've seen all of these concepts, how we actually cause hypocalcemia. What I want you to do now is take a second and say, okay, what causes low PTH? What causes the low PTH effect or the no PTH effect? What causes low vitamin D, and what causes high phosphates, high citrates, and high fatty acids? And we can answer our questions. Let's do that now. All right, so let's talk about the causes here. So we have to then take each one of those pathophysiological concepts and really build on it. So low PTH and low PTH effect, right? This is very, very straightforward now. What causes low PTH, which leads to low calcium? Well, one is you cut the parathyroids out. These are the source of your parathyroid hormone production. So oftentimes this is we can see this as a iatrogenic effect. So this could be after a parathyroidectomy, which could be an actual process that they're going for, but you can also see it in thyroidectomies, and this could be accidental. So in other words, they were going out to take some of the thyroid tissue and they accidentally took one of the parathyroid or two of the parathyroid glands. So parathyroidectomy or a thyroidectomy. So you can also see this in thyroidectomies, which lead to kind of an accidental taking or removal, I would say, of the actual parathyroid gland. If that happens there, boom, you just lost some sources of PTH. These are supposed to be able to produce PTH. Now you only have maybe one or two glands that are producing the PTH. So that could be one potential reason. And we know that PTH leads to less osteoclast activity, less vitamin D activation, and less calcium reabsorption. All right, cool. Here's another thing. If you look at the patient's history in this, and you'll oftentimes see this in the vignette, they just had a thyroidectomy, they had some type of neck surgery of sorts. If they had anything like that, oftentimes that's going to be the answer. There could be autoimmune diseases. There is like an autoimmune polyglandular syndrome type 1. It's very, very rare, and usually it presents with adrenal insufficiency and mucocutaneous candidiasis and hypothyroidism, but it's a really, really rare thing, and I don't think that you'll see it too often on the boards. What I would be thinking about, in true clinical reality might be more likely, is when a patient has no underlying neck surgeries or anything that was near the parathyroids, think about magnesium. So hypomagnesemia can also be a pretty common cause here. And that's because calcium and magnesium often kind of go hand in hand. Now, with hypomagnesemia, whenever there's low magnesium, magnesium is actually essential for the development, the synthesis, and the release of parathyroid hormone. So whenever a patient has low magnesium levels, this actually will kind of inhibit the parathyroid gland. And the parathyroid gland, as a result, won't be able to produce PTH. And so that's another really big one. Now the question comes up, what leads to hypomagnesemia? Why would patients have hypomagnesemia? Because that's what you have to look for in the vignette. It's not going to be super obvious. They're not going to probably give you the magnesium level. They're going to say some of the diseases that make them predisposed. What could be some of those things? Well, I would think about patients who have some type of bowel disease, so small bowel disease of sorts. What do I mean by that? Well, do they have any history of celiac disease? Do they have any history of Crohn's disease? Do they have any history of like a small bowel resection or some type of bypass surgery? That's what I would be thinking about, or a malabsorptive syndrome of sort. The other one I'd be thinking about is patients who drink a lot of alcohol. This can definitely be them not getting enough of their nutrients, in their actual diet. So alcohol abuse would be a really, really big one as well. And then chronic diuretics. So diuretic use can also definitely lead to hypomagnesemia. So these are some of the things. There's even sometimes, you may see this on the board, but PPIs also cause this as well. But this is what I would really be looking for that is a dead giveaway on the exam, is small bowel disease, alcohol abuse, and diuretics that lead to hypomagnesemia, shut down PTH production, and lead to hypocalcemia. The last one's really interesting. And this one is called pseudo-hypoparathyroidism. And I'll explain this one here in a second. But before I do that, I want you guys to notice something really interesting. Now, when patients have this PTH, right, low PTH, we know that their effect is going to be, they're going to go here and they're supposed to bind to this receptor on the bones, bind to the receptor on the proximal tubule and the distal tubule. And then hopefully as a result, it's supposed to reabsorb calcium here, lead to the activation of vitamin D, chew up the bones via the osteoclast. But what if there's a disease process that this isn't the problem? So this is one of them. But what if when PTH goes and binds here, I don't get this effect? Then what? This is an issue. Now, let's actually talk about this, because pseudo-hypoparathyroidism is kind of an interesting disease. It's kind of rare. It's a genetic condition. And the concept here is that there is some type of PTH receptor resistance. Oftentimes these patients have like weird metacarpal disorders, and sometimes, very common, there's some degree of mental retardation of effect there. But what happens is PTH is supposed to bind to these receptors. Now, when PTH binds to these receptors, it should then do what? Trigger the effects that we talked about with PTH. But if there's some type of receptor resistance, you're not going to get that effect. So this is due to PTH receptor resistance. So it's like PTH is not even present, essentially. What happens then? Well, if I don't stimulate osteoclasts, I won't reabsorb calcium. If I don't tell my DCT to reabsorb calcium, I won't get calcium to the bloodstream. And if I don't activate vitamin D, I won't absorb calcium across the gut. All of these things lead to what effect? Hypocalcemia. Well, hypocalcemia is a very, very, very strong stimulus for the hormone that's supposed to control him. And guess what that tissue is? It's the parathyroid glands. Calcium should then say, hey, parathyroids, calcium's low here, buddy. I need you to go ahead and pump that PTH up. And that's what is really, really weird about this disorder, is that now they're going to go ahead and say, okay, I got it. I'll pump up the PTH. And I'm going to do this in hopes that I'll be able to go back to the bones, back to the kidneys, and help us to get calcium. But it will have to no avail. It won't be able to do that. That's what's really important. This is where diagnostically this is super helpful. What do you notice with pseudo-hypoparathyroidism with the PTH levels? It's high. What do you notice with a parathyroidectomy, thyroidectomy, or hypomagnesemia? It's low. That's the difference here. That's what I want you to remember. Again, remember PTH, yes, it is supposed to go here to these actual sites and work on the bones and go and work on the DCT and the PCT and hopefully help to increase calcium. But in all of these scenarios, it won't. It's the exact same situation, except the receptors aren't responding. The parathyroid's fine. It's the receptors that aren't working. That's the difference between these two. And you can actually differentiate this by getting a PTH level. All right? Now, that's the low PTH or PTH effect. What about low vitamin D? Well, I kind of introduced this to you already. It's not too bad, but what if same thing? What if I have a disorder of my GIT? Yeah, it could be a lot of things, right? Let's say that you have some type of like malabsorption of sort. So this could be due to malabsorption. That can definitely cause this type of problem. What's another one? Well, what if there's decreased sun exposure? We see this a lot. And people who are kind of around the different parts of the equator, maybe people who have jobs where they're working inside, they're techies, they're not outside a lot. This could definitely be a very, very common one. So you see this a lot on the exams. Either way, if you're not getting in the proper nutrients because you have a malabsorptive disorder, or you're not being so exposed to the sun, what happens in both of these? They're supposed to help us to take in some degree of vitamin D in that cholecalciferol form, right? Will they be able to do that? No. So now you're not going to get that cholecalciferol, and that's where we kind of left off. If I can't get that cholecalciferol, well, eventually I won't lead to the formation of vitamin D, the active form. Here's another point. This is where I like to build on this, right? What's he supposed to do? Take and convert this into what? He's supposed to convert that cholecalciferol into what's called 25-hydroxy vitamin D. Now, if he's supposed to do that, what if a patient has underlying disease of the liver? What could this be? Cirrhosis, right? So if a patient has underlying cirrhosis, this will impair their conversion of that cholecalciferol into the 25-hydroxy vitamin D. Now I have less vitamin D here. Oh, son of a gun. Now, next concept. Your kidneys, the proximal convoluted tubular cells, are supposed to express what particular enzyme? The alpha-1 hydroxylase. Now, if it's supposed to express that enzyme, that should then do what? Convert this puppy into 25-hydroxy, baby, to 1,25 dihydroxy vitamin D. And this is that active form of vitamin D, right? Now, if I have some type of disease of my kidneys where the tubular cells are dying or the nephrons are dying, then will I be able to perform this process? No. So in the same way I can't perform this process, I can't perform this process. And so I won't be able to form him. And so in this situation, what could we see this where there's lots of death of the nephrons and disease of the nephrons and chronic kidney disease? So CKD is a really, really big one. Out of all of these, I really, really want you to remember this one. And I also want you to remember decreased sun exposure. These are oftentimes really big ones for the exam for a diminished vitamin D level. Now, the concept here is also really interesting because there's really one disease, two diseases, I would say, that cause low PTH. Parathyroidectomy, thyroidectomy, and magnesium levels that are low can cause hypoparathyroidism. Pseudo was high PTH. What do you think is going to happen with low vitamin D? What does it eventually lead to? It's supposed to go to the GIT, right? And absorb calcium. If I don't have that, will I absorb calcium? No. If I can't absorb calcium, what will happen to my calcium levels in the blood? They'll drop. What's calcium a very, 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 very strong stimulator of? PTH. And if it's going to be a strong stimulator of PTH, what will happen to the PTH levels in the bloodstream? They'll be high. So if PTH levels come back high, you got to think about pseudo-hypoparathyroidism and vitamin D deficiency. That's really important. If it comes back low, you think about hypoparathyroidism or hypomagnesemia. Either way, they're both a hypoparathyroidism. All right, the last scenario here, calcium sequestration. In calcium sequestration, it's important to remember that there is acute causes and chronic causes. The most important one for the chronic causes is going to be CKD. So I want you to remember this is the only example of like a chronic calcium sequestration. If a patient has disease of their kidneys, usually, for example, it's chronic kidney disease, it's kind of a perfect example here, they lose the ability to excrete phosphates. Because you know your GFR is low, right? You're supposed to be able to excrete phosphates. Now, if I can't excrete those phosphates, they're going to build up in the bloodstream. So that's the problem here is that what happens is they can't filter it out. And that phosphate builds up in the bloodstream, right? So what am I going to end up with a lot of? Lots of phosphates. Remember I told you with the high phosphates, what do? They bind the calcium. What do they do to the free calcium? They decrease the free calcium. So that's kind of interesting, right? That's the problem with this one here, right? Now we'll come back to this. All the rest of these, so this is the only chronic case, is CKD. All of the rest of these are acute. Now what that is important for is when it comes to the PTH levels, and I'll explain in a second. Acute diseases include rhabdomyolysis. Now, rhabdomyolysis, what is this? You break open, you destroy those skeletal muscle cells. This can happen when you have seizures. This can happen when you have crush injuries like trauma. But what does it do? It pops open, releases a bunch of different things, right? CK is the big one, myoglobin's the big one. But what's the other thing that's a problem for us? That phosphate. That phosphate, bruh. And when it pops that phosphate out there, guess what the phosphate does? It binds with the actual calcium. So now calcium is going to bind with this, and it's going to do what to my actual free calcium? This should be a red arrow, sorry guys. Free calcium is going to decrease. But this is acute, right? So I want you guys to please remember this. This is chronic, this is acute. And I know that sounds kind of dumb, but I promise it's important. Now, the next example is another disease, and this is acute as well. And this is called tumor lysis syndrome. We've seen this before. Remember in hyperkalemia we saw this? Same thing. Tumor lysis syndrome is in patients we see who have like what's called non-Hodgkin's lymphoma or acute myelogenous leukemia, and they get chemotherapy. And all of a sudden, that chemo kills all of those cells. They bust open. They bust open and release potassium because it causes hyperkalemia. They release uric acid, causes hyperuricemia. They release LDH, but what else do they release? They release phosphates. If they release phosphates, what's that phosphate gonna do, baby? It's gonna bind up the calcium. So you're gonna get that acute rise in the phosphate. Again, acute rise. Now, let me explain this for a second. Why is this so important? If it's an acute rise, whether it be rhabdo or tumor lysis, this will not cause the calcium levels to drop consistently enough to stimulate PTH production. If it's chronic, and only if it's chronic, this has the capacity to tell the parathyroid glands, hey, calcium is low, I need you to go ahead and start pumping out the PTH. All right, this is only if it is chronic. This will do this. If it's acute, we don't really know. It's super variable. And so you can get variable levels of PTH. For simplicity's sake, we're just gonna put the PTH as being somewhat between the normal range. So it's super variable. I'll put that here in the parentheses in the sense that we can't have a consistent determination of what their PTH level is gonna be. But when it's chronic, we can. And so that's actually helpful because this can be useful in determining diagnostically if it's CKD versus some other process. But we can also just base it on the acuity of their presentation of hypocalcemia. So rhabdo, tumor lysis, you're gonna see more in that acute phase. But if I have a patient with hypocalcemia and I check their PTH is low, it's hypoparathyroidism. If it's high, it could be vitamin D deficiency, pseudo-hypoparathyroidism, or CKD. I can't really make a definitive answer with the rhabdo or the tumor lysis. The last ones are pretty much similar in the sense that they're acute, but they release different things. You know when a patient gets tons and tons of blood transfusions? So I've seen this a lot in the ICU where a patient gets a ton of blood transfusions, and when they get lots and lots of blood transfusions, we're actually supposed to very, very closely monitor their calcium. And the reason why is like during, for example, a massive transfusion protocol, what happens is you give them so much blood, and that blood releases a very specific molecule that you give them, and it's called citrate. And that citrate we talked about before, guess what? Super negatively charged, guess what it's gonna do? It's gonna bind up the calcium. And when it binds up the calcium, it's going to drop the calcium super acutely. And so that's why in these patients who actually get massive blood transfusions, we tend to see their serum calcium levels drop acutely. And so that's a perfect clinical vignette where you would see this. The last one, it's not worth the squeeze to really, really remember this, but you can think about it. Hypocalcemia is funny because it can actually lead to, in some of these patients, you may see some type of issue, particularly as a result of pancreatitis. And why I laugh is because hypercalcemia can cause pancreatitis. So hypercalcemia can cause pancreatitis, and hypocalcemia can be the result of pancreatitis. It's just funny, I don't know why. But anyway, when we talk about pancreatitis, guess what happens? In some situations of pancreatitis, you'll release out the enzymes like your lipases, and those lipases son of a gun. What are those lipases supposed to do? Those lipases, they end up unfortunately breaking down the fat tissue in the pancreas, all the peripancreatic fat tissue. When they break down the fat tissue, It breaks it into what's called fatty acids. And if we have lots of these fatty acids, guess what that's going to do? So if I get lots of lipases, it's going to help to convert the fat into fatty acids, and those fatty acids are going to build up in the bloodstream. If they build up in the bloodstream, what are they going to do? They're going to bind to the calcium ions. And if they bind up to the calcium ions, what's that going to do to your whole serum calcium? It's going to drop your serum calcium. And so sometimes we actually give this a very interesting term. We call it saponification. And so we can see this in patients who have what's called acute pancreatitis. So please don't forget these things. Now, we've talked about hypocalcemia. What I want to do is go through hypercalcemia. So now let's talk about hypercalcemia, which is the other spectrum of calcium disorders. So this is when the calcium is too high. So calcium too low, less than 8.5, calcium too high, greater than 10.5. Now, when we talk about when the calcium is too high, we have to think about, again, the pathophysiological concepts. What are the reasons why? Well, one of them is that the PTH is just too dang high, right? You're making too much of that parathyroid hormone. Now, when we talk about this, we kind of are going to be repeating what we talked about in hypocalcemia, so I won't waterboard you with all of this stuff, but PTH, if you're making a lot of this, again, parathyroid glands are usually the primary source. Now, if you're making a lot of this, puppy, what is it going to do? Let's just have a quick reminder. It's going to act on the, what? The bone, right? Particularly what? The osteoclast. When it works on the osteoclast, it does it technically indirectly by working on the osteoblasts, which then help to activate the osteoclasts. In this case, we're going to stimulate the osteoclasts, who are then going to start breaking down the bone tissue. When they break down the bone tissue, they'll liberate and release the calcium from the bone tissue. And this is going to be the mechanism, what we call increased bone resorption. So you're actually resorbing some of the calcium from the bone. So this is increased bone resorption. And this will, when you liberate that calcium into the bloodstream, lead to high calcium in the blood. So that's one mechanism. PTH also likes to act here on the kidneys, and particularly at the distal convoluted tubule. And again, we know that this acts via these different types of receptors, the PTH receptors. Same thing, there's PTH receptors here on the distal convoluted tubule. Now when it acts here at the distal convoluted tubule, what it's supposed to do is increase, oh, son of a gun, that went far. What it does is it actually increases the expression of a channel that plays a role in calcium reabsorption and phosphate excretion. Now, when it binds to this receptor, it's going to stimulate this receptor, who then helps to activate the expression and the opening of these channels, which will then allow for calcium to be reabsorbed and phosphate to be secreted. As a result, as we do this, you will reabsorb calcium into the bloodstream, because you're going to be pulling it from the kidneys into the bloodstream. So there's going to be increased what's called calcium reabsorption via the kidneys. But as a byproduct, whenever you actually are going to stimulate PTH, you can remember PTH, also known as what's called the phosphate trashing hormone. So it will actually excrete the phosphate into the urine. So what will happen to the phosphate levels in the bloodstream? It should theoretically drop. And so that's one thing that we see whenever parathyroid is actually the issue, is that calcium will go up and phosphate will go down. Now, that's one mechanism, right? So we got 1, 2, what's the third? Again, I don't want to clutter the diagram here, but it acts on the proximal convoluted tubule. So when it comes here, it acts on the proximal convoluted tubular cells in the kidney and increases the expression, yeah, you guessed it, of the alpha-1 hydroxylase. Now, if we increase the expression of this enzyme, what's going to happen? I will then convert 25-hydroxy vitamin D, which is made by the liver, into 1,25-dihydroxy vitamin D, which is then going to be the active form, who helps to facilitate this PTH by increasing the expression of this enzyme, who then will stimulate the rapid conversion into this. If I have more of this, what's going to happen? He'll then go to the GIT, he'll plug some calcium channels into the luminal membrane. If you plug calcium channels here, what's going to happen? The more calcium channels, the more calcium can move across the GIT. And if you have more calcium coming across via the GIT, what's going to happen? It's going to increase the calcium in the bloodstream. And this is going to be via increase calcium absorption across via the GIT. Ooh, baby, we good, right? So it's going to stimulate this process. You're going to express these more. Now, the next concept is, what if PTH isn't really the problem? What if it's due to vitamin D, excess vitamin D? Now, it is possible to develop a vitamin D intoxication. It's just not as common as some of the other diseases that we can talk about here. But again, you have to remember that cholecalciferol, which is the super inactive form of the vitamin D, can come from the gut, and it does come from the skin, right? Now, if patients do they ingest way too much vitamin D, it is a possibility that they could develop hypercalcemia as a result. But we'll see down here a little bit later that there's another interesting process. Now, cholecalciferol goes to the liver. And when it goes to the liver, again, what we know is that the liver will help to convert that into what's called 25-hydroxyvitamin D. 25-hydroxyvitamin D. Now, you're probably like, oh, probably something wrong with the liver, right? The liver is probably the reason why, and it's hyperactivating. Not necessarily. So you're like, okay, all right, well, where's the issue actually occurring here? Well, the next thing is that you know that the kidneys express this enzyme called 1-alpha hydroxylase, right? And that 1-alpha hydroxylase, or the alpha-1 hydroxylase, what we know about this enzyme is that he helps in being able to convert 25-hydroxyvitamin D into 1,25-hydroxyvitamin D. And so what we know is that with the presence of this enzyme, what we will see here is, so whenever you have the expression of this enzyme, this helps to stimulate the formation of 1,25-dihydroxyvitamin D. This is usually where the problem exists. Now you're probably like, oh, it's the kidneys, right? There's something going on with the kidneys. Not necessarily. And that's what we'll talk about later. But oftentimes the problem with excess vitamin D is usually an increase in this enzyme. And we'll talk about how certain tumor cells have the capacity to overexpress this enzyme, or granulomatous cells have the capacity to increase the expression of these enzymes. There is the possibility of us taking in way too much vitamin D across the diet. That also can cause this, but more particularly through the pills itself. Either way, when you get too much vitamin D in the body, what happens? If there's too much of this active form of the vitamin D, he'll go to the GIT. When he goes to the GIT, he will increase the expression of these calcium channels. Absorption of calcium leads to hypercalcemia. The next one is PTHrP. Now, PTHrP is what's called parathyroid hormone-related peptide, meaning it's not parathyroid hormone, it can act like it. This is released by very specific types of cells. And again, I want you guys to start getting yourself ready of trying to ask yourself, what kind of cells is PTHrP released to a lot in? What type of cells are releasing increased alpha-1 hydroxylase? But regardless of that, if we make lots of PTHrP, and we're going to kind of keep these cells somewhat of a mystery for right now. When that PTHrP is released, guess what it does? It kind of acts just like parathyroid hormone, except it does one less thing. So what it's going to do is, this should be the blue arrow here, guys. It's going to act on the bone tissue, and it's also going to act on the kidney tissue, but only on the distal convoluted tubular cells. So what it's going to do is it's going to stimulate these osteoclasts, right? You know the osteoclasts? It's going to increase the osteoclast activity. When you increase osteoclast activity, you're going to resorb the bone tissue. When you resorb bone tissue, what's that going to do to the calcium levels? It's going to increase the calcium levels because you're going to liberate calcium from the bone, right? The other thing that it's going to do is it's going to increase the expression of the channels in the distal convoluted tubule to reabsorb calcium and excrete phosphate. So in this process, you'll reabsorb calcium and you'll excrete phosphate. It'll stimulate this process. And if this occurs, what's going to happen? This will lead to increased calcium reabsorption, which will then lead to increased calcium. The only thing that PTHrP does not do is it doesn't play a role in activating the vitamin D via the 1-alpha hydroxylase. That's the only difference between these two. All right, that's very important as well. This is the concept for PTHRP. So, all right, we know now, high PTH, high vitamin D, high PTHRP is the reasons why patients would develop hypercalcemia. There's one last one. This last one can exist whenever you have lots and lots and lots of bone turnover. So imagine here we have a bone tissue. And in the bone tissue, again, we always have these cells, the bone-eating cells called osteoclasts. And these osteoclasts, it's important to remember that they have receptors on them, right? They have lots of different receptors that can respond to cytokines and ligands of all kinds of sorts. If someone has diseases, all right, particularly malignancies, that super activate these osteoclasts, what can they then go and do? They can then say, all right, baby, I'm gonna chew through this bone like a son of a gun. And they are going to massively, massively increase bone resorption. And if you increase your bone resorption, you're going to, as a result, liberate calcium from the bone. So here you can see bone resorption. Here you're going to see tons and tons of bone resorption to the point, and which we'll talk about this later, it starts to eat through the bone tissue. And these start to cause a lot of problems here to the bones and cause a lot of bone disease. So looking at all of this is the framework that I want you to form in your head when you think about a patient having hypercalcemia. Is it high PTH, high vitamin D, high PTHRP, or lots of bone turnover? Let's now go through each one of these and think about the causes of those scenarios. All right, so now we've formulated our kind of overall understanding, right? Now let's go through each one, talk about what's causing these particular concepts. So high PTH, we know that because it's acting on the osteoclast, it's acting on the proximal convoluted tubule, distal convoluted tubule, we got that all down. We just gotta ask ourselves the question, why is PTH high? There's two reasons. One is what we call primary hyperparathyroidism. Hyperparathyroidism. And again, if you guys are having any confusion, we talk more about parathyroid disorders in the endocrine section, so go watch that if you need a little bit more help. But primary hyperparathyroidism is oftentimes due to an adenoma. So oftentimes the patient will have like an adenoma that is causing this. There is other reasons, but I would say, often more than not, it's an adenoma that's usually present 80% of the time that is pumping out. It's gained the capacity, an autonomous capacity to produce PTH in large amounts. So this thing is just straight pumping out the PTH. Now, we know via what we just talked about here, that if you're pumping out lots of PTH here, we know that this is going to work because it goes down to the bone tissue, the osteoclasts, and it goes down to the kidneys via the proximal tubule and the distal tubule. And what does it do at these particular areas? It works by stimulating osteoclasts to increase bone resorption, increases the distal convoluted tubular cells to cause calcium reabsorption, and increases the expression of alpha-1 hydroxylase to form more vitamin D, lead to more calcium. So either way, in all of the scenarios here, we lead to a patient developing what? High calcium as a result. Now, here's where it's really, really important. PTH is the reason the calcium is high. There's another disease, and this is called tertiary hyperparathyroidism. Now, you're probably like, okay, Zach, you skipped one of them. Because does it go primary, secondary, tertiary? Yes. Secondary hyperparathyroidism is oftentimes defined as patients who have CKD or vitamin D deficiencies. When they have those, they produce hypocalcemia, and that hypocalcemia, as we talked about in the hypocalcemia portion, stimulates PTH production. And that PTH will go up and up and up, but it's not gaining the capacity to cause the calcium to go up. What happens is chronic kidney disease is one of the really prominent secondary hyperthyroid states that if continuously occurs and progresses over time, that can lead to tertiary hyperparathyroidism. Let me explain. Let's say here I have a patient who has CKD. And this is oftentimes, usually, the most common cause. And patients who have CKD, they lose two things. One is they lose the ability to excrete phosphates. We talked about that in the hypocalcemia portion, right? So phosphates go up. The other thing is they lose the capacity to express lots of Alpha-1 hydroxylase. What does that lead to? Less conversion of 25 hydroxy vitamin D to 1,25 hydroxy vitamin D. Now I'll have a decreased vitamin D. Now here's what I want you to remember. If I have high amounts of phosphates and I have low amounts of vitamin D, they just work through different mechanisms. But both of them end up with the same result, which is what? They end up with a patient developing what? Hypocalcemia. Now you're probably like, okay, Zach, wait a second. We're talking about hypercalcemia, bro. What's going on here? Hang on. We know that high phosphates will bind up the calcium and reduce the free calcium. We also know that low vitamin D won't absorb calcium across the GIT. This is what leads to low calcium. Now here's what's cool. This low calcium will then just peck away at the parathyroid gland constantly, continuously. This part here, this is secondary hyperparathyroidism. What happens is once these parathyroid glands start to undergo hyperplasia, they gain what's called autonomous hypersecretion. What the heck does that even mean? All that means is that I tell these parathyroid glands to replicate, and then they gain the capacity on their own, like an adenoma, to start pumping out PTH. When that conversion occurs, that is when we've reached the state of tertiary hyperparathyroidism. Now watch what happens here. Once that occurs, we're gonna pump out so much PTH, it's absolutely insane. When this PTH is pumped out in super high amounts, guess what happens? It then goes over here, same thing. It's gonna go to the kidneys and it's gonna go to the bone. But it prefers, because the kidneys are damaged, to really target this one very, very heavily. And what it's going to do is it's going to massively stimulate osteoclastic activity to break down the bone tissue and lead to massive bone resorption. This is the difference. So when you look at these two here, they both have high PTH levels. They both have high calcium levels. But what's the difference? What do you notice here? This one's going to have high phosphate. What happens if you have high PTH and good kidneys? You dump phosphate. So oftentimes in patients who have primary hyperparathyroidism, they have hypophosphatemia. Patients with tertiary hyperparathyroidism have hyperphosphatemia. That's a big difference. Also, low vitamin D. If you have high PTH, you'll have high vitamin D. That's an important thing to remember for these. All right, so we talked about these pretty good. I think we have a good idea of the differences between these two. High PTH, high PTH, high calcium, both have high calcium. This one has high phosphate, low vitamin D. This one has low phosphate and high vitamin D. All right, let's now move into the next step. Vitamin D too high. Now, if the vitamin D is too high, what's the reason? Oh, bro, you're just popping vitamin D pills every day. Yeah, it's gotta be the reason, right? No, that's not the reason oftentimes. Oftentimes, it's due to rare granulomatous disorders. What the heck does that even mean? Zach, what you talking about? Oftentimes there's a disease, it's called sarcoidosis, and another one called Hodgkin's lymphoma. So let's say that a patient has lymphoma, particularly we see it more commonly in Hodgkin's lymphoma, or you have sarcoidosis. These are oftentimes what we define as like granulomatous diseases. Now, these granulomatous diseases, have the capacity to increase the expression of a very special enzyme that I talked about to you. What is that enzyme? This is the alpha-1 hydroxylase. Now you're like, okay, all right, Big Daddy's in. I got it. I know now what he's talking about. If I increase the expression of this enzyme, if these tumor cells or granulomas increase the expression of this enzyme, why is that important? If you remember, the liver helps to convert what's called cholecalciferol into what's called 25-hydroxy vitamin D. And then, what does this enzyme do? He takes and converts this bad boy into 1,25 dihydroxy vitamin D. Now, if I have this guy present and he's stimulating this like a son of a gun, woo, baby, we're gonna have a lot of this. And if we have a lot of this, what are you gonna do? It's gonna go to the GIT, it's gonna stimulate the expression of these luminal calcium channels. If I have lots of luminal calcium channels that are present, guess who's gonna come flowing across this? Calcium. So I'm going to get increased calcium absorption across the GIT into the bloodstream. Now, here's where it's important diagnostically. PTH is high in hyperparathyroidism, primary and tertiary. But PTH should theoretically be low in these states. Now I'll explain why. Because if calcium's coming up, what should that do to the parathyroid? It should suppress him. So now, this calcium is going to go to the parathyroid, shut him down, say, hey, shut her down, boy. And that's going to drop the PTH levels. So if you check a patient's PTH levels and you find that they're low, you should suspect high vitamin D. If you check it and it's high, you should suspect hyperparathyroidism, primary versus tertiary. All right, so the next situation is, what if the PTHRP is the problem? So, all right, so it's not high PTH. And if it's not high PTH, then it's probably a low PTH state. If it's low PTH, you think about, oh, okay, could it be high vitamin D? If it's not high vitamin D, you think about the high PTHRP. Now, with this particular scenario, we oftentimes see this in lung cancer. I'd say it's the most common type of malignancy that you can see this in. All right, and it's usually seen in what's called the squamous cell type. All right, so squamous cell cancer or carcinoma. So you can oftentimes abbreviate that SCC, right? So we can see it in lung, but you also can sometimes see it in breast cancer. All right, and again, what type is it again? Squamous cell carcinoma. And sometimes you can even see it in renal cancers. And again, that's going to oftentimes be squamous cell carcinoma. Now, the big thing with this is that these cells have what's called a paraneoplastic syndrome. In other words, they gain the capacity to secrete these types of peptides. So to pump out PTHRP. If I'm going to pump out lots of this PTHRP, because it is produced in normal amounts by certain types of tissue cells, but it shouldn't be produced in large amounts. And if I'm producing it in large amounts, what's the end result? Well, it's the same thing I told you guys. It goes to the osteoclast, and it stimulates the osteoclast to do what? Increase bone resorption. It goes to the kidneys, but it only does one thing at the kidneys. It increases calcium reabsorption. It does not lead to the formation of active vitamin D. So vitamin D levels would be low, what in this one? It would be low, right? The vitamin D levels would be low in this one because it doesn't lead to the activation of vitamin D as much. This one would have high vitamin D. This one wouldn't have as much of a high vitamin D. It should usually be normal or low. In this situation now, what's going to happen? I'm going to liberate, sorry, wrong color. I'm going to liberate calcium from the bone, and I'm going to reabsorb calcium across the distal convoluted tubule. That's going to increase the calcium in the bloodstream. What does increased calcium do to the parathyroid gland? Suppresses the parathyroid gland. What will the parathyroid gland do as a result? Shut down its PTH production. So we can see here how if you have low PTH levels, think about vitamin D and PTHRP being elevated. Okay, my friends, we come to the last particular cause and scenario here of patients having hypercalcemia. What if it's lots of bone turnover? Okay, I told you before that it had something to do with the osteoclast. They were going absolutely ham bone. And if these osteoclasts, if you're having massive osteoclast activity, what's the issue with this? Well, again, I told you they have receptors, right? They have these receptors all over them. They can be very heavily influenced by cytokines and other ligands. And patients who have what's called lytic lesions. So you see this, it's a kind of, you're destroying the bone. So we have lytic lesions. There's two differentials that I'd want you guys to consider. One is multiple myeloma. So multiple myeloma is definitely going to be a big one. So it's when those plasma cells are pumping out lots of those immunoglobulins, and sometimes the plasma cells can infiltrate into the bone tissue, right? That's one big one. The other reason is bone metastasis. I had to be quiet because I had to think about how to spell these dang things. But in patients who have lytic lesions, it's usually due to multiple myeloma or bone metastasis. Now, oftentimes in multiple myeloma, it can release like a molecule. I don't want to get too crazy, but it can release these different types of ligands, like what we call rank ligand, and this may directly activate the osteoclast. Bone metastases, they may also release certain cytokines like interleukins and tumor necrotic factor alpha that may stimulate these osteoclasts. What I want you to remember is when you have this effect, these tissues and these lytic lesions, they are going to massively stimulate these osteoclasts to go haywire. When they go haywire, they are just going to start causing massive bone resorption. They're going to chew through this bone. Look at this. It's just wearing away. Now, when they do that, what's the obvious effect? We already kind of talked about it. We're going to liberate calcium from the bone. And this is going to cause hypercalcemia. Now, that hypercalcemia, when we get lots and lots of calcium into the bloodstream, what can that do to your parathyroid glands? Again, it should suppress the parathyroid glands. It should say, hey, bro, the calcium is too high. You got to shut down your PTH so that this thing isn't pumping it out as much. And if I shut down the PTH production, this hopefully, theoretically, will cause less calcium to be formed. In other words, from the bone, from the kidneys, and from the vitamin D activation. Big thing to remember though with this is we talked about a lot of these things, right? How would I know multiple myeloma from bone metastases? We'll talk about this later. Sometimes it can come down to what's called alkaline phosphatase. And also for this one, you would check what's called an SPEP. But we'll get into the diagnostic measures. What I want you to think is, oftentimes in patients who come into the hospital who have hypercalcemia, the most common cause, 50% of the time, is hypercalcemia of malignancy. And what are things here that you see as a result of malignancy? Lytic lesions. So if a patient has lytic lesions like multiple myeloma, bone metastases, this can cause hypercalcemia malignancy. Anything that causes an increase in PTHrP, this can cause hypercalcemia malignancy. And even in these particular situations, maybe like having Hodgkin's lymphoma, this can even potentially cause hypercalcemia malignancy. So I don't want you to forget that in the sense that hypercalcemia malignancy is the most common cause of inpatient hypercalcemia, whereas hyperparathyroidism is the most common cause of outpatient hypercalcemia. All right? All right, my friends, we have talked a ton and dedicated a lot of time into understanding the pathophys, the causes. Let's dig right into the complications of why calcium can be so detrimental if it's too high or too low. All right, my friends, so now we've talked about the reasons as to why the calcium's too low in hypocalcemia and the calcium's too high in hypercalcemia. We now need to understand, how would a patient who has hypocalcemia and hypercalcemia present? Because that's oftentimes the most important thing. Oftentimes, more than not, they're asymptomatic. You may get lucky and find a couple different manifestations, but oftentimes this is an incidental finding that you obtain during a workup of something else, or you get routine labs and you find that their calcium's high or low. But let's talk about this pertinent to the exam, because that's how they're going to try to trigger you to think about this in the vignette. So hypocalcemia, one of the biggest findings is neuromuscular irritability on the exam. The concept behind this is actually pretty simple. Let's say you have too much calcium, right? Too little calcium. The reason why that's a problem is calcium naturally sits to some degree around these voltage-gated sodium channels on neurons, right? And so let's say that you have less calcium. That means that you'll have less positive charges around these voltage-gated sodium channels, right? So again, essentially, if you have a decrease in your calcium, such as in hypocalcemia, there'll be less, let's say, blockage of the sodium channels. Now, if you have less blockage of the sodium channels, that means that if sodium is present in an adequate amount and you have less of this calcium to block this, when these channels are open, oh baby, are they open, and they will flood with sodium. And so what will happen is in this particular scenario, you'll increase the sodium influx more than usual if a patient has low calcium, because again, they have less positive ions around the edge. Because sodium is positively charged. If I have calcium ions here, they're also positively charged. What would the positively charged ions do to each other? They would repel. So that kind of, when you think about it, it prevents sodium from rushing into the cell. If I have less calcium, I'll have less repulsion. And it'll be less repulsed, right? And so it'll rush into this neuron. If it rushes into the neuron, all the sodium, what's going to happen is it's going to cause the inside of the cell to become super positive. And what this will do is it'll generate an action potential. And if I generate a lot of action potentials down this neuron, what's going to happen? This can then present with kind of excitability of the nerves, but it can release neurotransmitters such as acetylcholine, and that acetylcholine may stimulate these muscles to contract as well. And so that's the concept, is that this nerve is super excitable, and then it'll also stimulate the muscle, And if the muscle becomes hyperstimulated, it will trigger an increase in contraction of the muscle. If this does happen, here's what we need to think about. If a patient has excitable neurons and excitable muscles, how could they present? One way, in the worst case scenario actually, could be seizures. Now, these seizures is usually the worst case scenario, and I would say it would actually be the least likely, but it is possible. Now, the concept behind this is that you're causing neurons in particular areas of the brain to become super irritable, and you're creating this cortical irritability. And that cortical irritability is enough to be able to trigger seizures to form. Oftentimes, this could be tonic-clonic, this could be focal, but I'd say if you have some kind of metabolic process, more common than not, you'll generate some type of generalized seizure. Another one that they love to put on the exams is tetany findings. So one of them you can see here is called perioral paresthesias. And this is basically when the patient develops numbness and tingling around this area of the mouth. That's pretty straightforward, right? I think that's pretty self-explanatory. Here's the one that's interesting. If I come over to the side of the face and I tap, 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 right here is my nerve called the facial nerve. So if I tap on the facial nerve, so let's say I tap on the facial nerve, this is cranial nerve 7, that should cause, if it's super excitable, it should cause contraction of the facial muscles. So you'll activate the facial nerve, so you'll stimulate cranial nerve 7, and this will cause facial contraction. What is this called? What is this? You know what this is called? This is called Chvostek's sign. And so we can see this in patients who have hypocalcemia. It's called Chvostek's sign. Now, these are the big things to think about, all right? The last type of presentation here, and this is interesting, is let's say that you take a blood pressure cuff, right? And what you do is you inflate the blood pressure cuff. And when you inflate the blood pressure cuff, you kind of activate some of the nerves that are running through the arm. Maybe it's the median nerve of sorts. But you'll stimulate a peripheral nerve. When you stimulate that peripheral nerve, it'll cause, especially if it's like the median nerve, it can cause some contraction. And what happens is if you can cause carpopedal spasms. And so this may create a carpopedal spasm. The most common example that we can potentially see with this is the carpal spasms, and we see this when we inflate the blood pressure cuff in the arm, and it causes intense flexion at the wrist. And this is usually when you inflate the blood pressure cuff to a couple millimeters of mercury, usually 20, 30 above what their systolic is. When we see this kind of like flexion 3 minutes afterwards, this is called Trousseau's sign. Okay, so Trousseau's sign is going to be when you inflate the blood pressure cuff, they have carpal spasm maybe a couple minutes after you inflate it above their systolic. And then if you tap the facial nerve and it causes contraction, ipsilaterally, that's Chvostek's sign. These are the big things to remember, but I want to add one more thing to it because this is actually kind of a high yield fact. If you have a patient, what we notice is all of these can be exacerbated. We can literally exacerbate all of these. What could exacerbate this? So you can increase the, let's call neuromuscular excitability via hyperventilation. You're probably like, what the heck? How would I do such a thing? It's actually quite interesting. I'm not going to go crazy into detail, but what I want you to know is when a patient hyperventilates, what they do is they blow off their CO2. When you blow off your CO2, you decrease your partial pressure of CO2. When you decrease the partial pressure of CO2, you do what to the pH? You cause the pH to rise. When the pH rises, guess what that does? It actually causes more sites on albumin to open up because albumin is negatively charged and it likes to bind to protons. If your pH is going up, you have less protons. If you have less protons, you have increased free albumin. And guess who loves to bind to albumin if he can? Calcium. And if you can do that, it'll bind the actual calcium and decrease it even more. So if you have hypocalcemia, you hyperventilate, blow off your CO2, increase your pH, you can have more free albumin, which will bind the calcium. And if you bind the calcium, that'll decrease your free calcium and worsen the hypocalcemia and worsen these signs, or precipitate these signs. Okay, so the next thing here that's really important is with hypocalcemia, you can develop arrhythmias, but I would say it's more particularly ECG changes that increase the risk of you developing a scary arrhythmia. Now, calcium's interesting because it's involved kind of within the plateau phase of the action potential within the contractile myocardial cells. So it's supposed to be moving into the cells during the plateau phase. Right? So what happens is calcium's movement is obviously dependent upon, its concentration gradient to a degree, right? And so what we want to have is we want calcium to be able to move into these cells. But if there is less calcium present out here, it will interfere with that normal gradient. And what actually ends up happening is something kind of odd, which is that when you look at the duration of the plateau phase, it's now kind of prolonged, and their entire repolarization phase is then prolonged, right? So if you notice that, you'll notice kind of a delay or a prolongation in that kind of like entire repolarization period in the plateau phase. And so what that ends up kind of doing is it leads to changes in their ECGs. And so what we notice is we start to notice that their QT interval begins to become significantly prolonged. And so we'll notice an increase in their QT interval. Now, why is that a problem? The reason why this is a problem is when the QT interval begins to prolong, it increases the risk of a patient developing a very disastrous arrhythmia, and that arrhythmia is called torsades de pointes. So that's what you want to be kind of fearful of here in this scenario, is it does increase the risk of what's called torsades de pointes. And the problem with torsades de pointes is that this can obviously break down into ventricular fibrillation and lead to cardiac arrest. Oftentimes in patients who have what we refer to as the three lows, so if you have hypocalcemia, hypomagnesemia, and hypokalemia, these are the three particular electrolyte derangements, that can then lead to this prolonged QT interval and increased risk of torsades de pointes. All right? So that's the big thing, is watch out for the prolongation of the QT interval. I like to think about these as inversely proportional, in that the sense that this, more specifically the calcium, will lead to an inverse proportional relationship with the QT interval. And so that's kind of helpful when you look at this. And that's why whenever we get into hypercalcemia, what do you think it'll do? If it's high, then it's going to decrease the QT interval. All right, let's now move into our next component here, which is hypercalcemia complications. All right, so now we're gonna move on to the complications of hypercalcemia. So what's completely fearful with this one? Well, oftentimes same thing. A patient with hypercalcemia is oftentimes asymptomatic. We usually don't see symptoms or clinical manifestations of hypercalcemia until the calcium gets to greater than 12 generally. As we get closer to 14, we start seeing some severe symptoms. A lot of the times in school, you can remember the mnemonic: stones, bones, thrones, groans, psychiatric overtones, and I like to add in the last one, arrhythmia prone. But that's a mnemonic that may help you in remembering the clinical manifestations and complications of hypercalcemia. Let's go through these. So stones. Nephrolithiasis or kidney stones is a very high-risk complication, usually from chronic hypercalcemia. The concept here is that if patients have hypercalcemia, especially hypercalcemia malignancy or hypercalcemia due to high PTH states, they're going to have a lot of calcium in their bloodstream. When you have high calcium present within the bloodstream, that's not actually the specific issue. The issue really exists when that calcium then gets filtered into the urine. And when it gets filtered into the urine, we call that calciuria. So when patients have what's called increased calcium in the urine or hypercalciuria, that is really the issue, because this can now bind with things like oxalate and phosphate and increase the risk of kidney stones. All right, and so if combined, this increases the risk of kidney stones. Now, again, I think the biggest concept here is when you form kidney stones in these patients with hypercalcemia, you're gonna have to think about the common complication that they'll have, which is, or the presentation that they'll have. They'll usually have that flank pain, They can also have nausea, vomiting, and they may even have hematuria if it's kind of stuck within the ureter and it's causing a little bit of damage to the epithelial tissue. So again, hypercalcemia leading to hypercalciuria, and if that calcium binds with, oxalate or citrate, oxalate or phosphate, it can lead to calcium. I'd say the most common one is going to be oxalate stones. These are the most common type of nephrolithiasis, so type of stone. Now that's one thing, so stones. The next one's bones. Now this one's actually kind of interesting in the sense that if you think about every type of reason that a patient develops hypercalcemia, except for like maybe the vitamin D excess, if you have high PTH, if you have PTHrP that's elevated, or if you have lytic lesions, what does this start to do to the bone? It's one of the ways that we generate high calcium, right? So you're liberating calcium from this area, and that's how the patient's developing hypercalcemia, right? So this is oftentimes the result of what happens when you try to resorb bone, right? So things like high PTH, high PTHrP, or lytic lesions, when you activate those osteoclasts, if you have any of these particular things, they're going to really lay down this wasteland of lytic lesions, and they do that by helping to activate these particular cells, which are the osteoclasts. If you stimulate these osteoclasts, these will tear away the bone, right? So they'll increase your bone resorption. Now, when you start chewing through the bone, obviously the end result is that you can lead to hypercalcemia. But what happens is, after you continue to lead to this, you start to chew through the bone enough that it increases the risk of lots of complications. One of them is you can get these moth-eaten holes into the bone. When you look at an x-ray, you see all these like moth-eaten holes appearance. This is called, and cyst, osteitis, cystica fibrosa. And this is kind of like what we call moth-eaten hole appearance and cyst appearance on x-rays. Another one is you make the bone super porous, right? So you can literally lead to osteoporosis. This can be accelerated osteoporosis. And the last thing is, if you chew through this bone, you make this bone super brittle, and you definitely increase the risk of pathological fractures. So in other words, pathological fractures, there's a lot of different areas that these can occur. Long bones like the femur, the humerus, but the spine is also a big one, so you can get kind of compression fractures there as well. So all of these are the potential complications that can result from a lot of bone disease, particularly due to hypercalcemia, right? Now, the big thing is how will these patients present? Well, if they present with osteitis cystica fibrosa, they may present with some degree of pain in the particular bone that's being eaten away. Osteoporosis, they may present with that pain as well. But if they come in, what's the biggest way that they could potentially present? Pathological fractures, all right? So you may find this based upon the presentation of pain in a fracture, or you may find it via some type of DEXA scan, scanning bone density, or getting an x-ray and seeing these cysts and moth-eaten hole appearance on x-rays. So that's the big thing with a bone disease. The next one's nephrogenic diabetes insipidus. This actually tends to be, I'd say, one of the more common presentations I've seen in patients who have hypercalcemia greater than 12. Concept here is actually kind of interesting, and it's one of the biggest reasons why hypercalcemia severe needs to be treated with IV fluids, is based upon this concept. ADH is a hormone that binds onto what's called the V2 receptor in the distal, the collecting duct. And when it binds on here, ADH is supposed to stimulate this receptor and hopefully tell this receptor an intracellular signaling mechanism to increase the expression of aquaporin units. And aquaporin units are supposed to help to bring water across the luminal membrane, across the cell, and into the bloodstream. That's the job of ADH, to reabsorb water. When you have a patient who has super high calcium, right, what happens is, and this is actually kind of interesting here, the calcium will then kind of send some signals here that will shut down this interaction. So what it's going to do is it's actually going to shut down this interaction. So ADH won't be able to precipitate this effect here on the receptor. It won't be able to stimulate this process here, so you won't be able to reabsorb water. There'll be less reabsorption of water. So there'll be decrease in water reabsorption, and as a result, where's that water going to go, my friends? Right into the urine. And as a result, these patients will lose tons of water into the urine. We call this polyuria. And that polyuria can lead to hypovolemia. It can lead to dehydration. But also it can lead to so much water loss that the patient could develop hypernatremia because you lead to so much water loss, especially if they're not keeping up with their water intake. And so this is a big thing to remember, is it can cause dehydration and hypernatremia. So oftentimes when a patient comes in, they'll say stones, kidney stones, bones, bone pain, thrones, they're peeing all the time. That's the concept there. All right. So oftentimes these patients will come in with polyuria, polydipsia, oftentimes dehydration, and maybe even some hypernatremia due to water loss. This is a very common presentation. All right. We come to the next one, which I'd say is a less common presentation, and that is pancreatitis. Now this one's slightly a little bit of a stretch. When we say stones, bones, thrones, groans, we do know that hypercalcemia can do a couple things. I'm just going to quickly annotate it because this is not the only reason for the groans, but high calcium can also induce what's called constipation, which can definitely cause abdominal pain, and it also may increase the risk of peptic ulcer disease. So if you have this, this can also cause abdominal pain. But I'd say these are the less common of the situation here. What I would want you guys to remember is that it can increase the risk of pancreatitis. When a patient has super high calcium, what we notice here, and this is actually kind of perfect, it worked out here. When we look at the pancreas, we have the acinar cells in the pancreatic duct, right? The acinar cells are responsible for making these enzymes, these inactive kind of molecules, which we refer to as zymogens. These are kind of just inactive pancreatic enzymes, like pancreatic proteases and lipases, etc. That's what these things are, the zymogens. If calcium is present, calcium actually may be able to convert these into active enzymes. And so now I could have active enzymes here who now inadvertently I activated because of my high calcium. Guess what these puppies can go and do? These active enzymes can now start causing unfortunate destruction of my pancreatic tissue. And that's what they'll do. They'll actually start causing inadvertent destruction of the pancreatic tissue and inflammation of the pancreatic tissue. So that's the effect that this high calcium can have, is it could stimulate the inadvertent activation of pancreatic enzymes and lead to digestion of the pancreas, leading to pancreatitis, increasing the presentation of abdominal pain. So that's another thing to think about, okay? So there's stones, bones, thrones, groans, psychiatric overtones. This one's interesting as well, in the sense that when a patient has, again, too high of calcium, what does the calcium do? You got lots and lots of calcium blocking these voltage-gated sodium channels. If you have lots of calcium, right, and what are they going to do? They're going to block the sodium channels. What is that going to do to the sodium influx? Well, I think you just answered it. You're going to block it. The calcium is not going to be able to move into these cells as easily. Why? Because they have positive charges that are repelling them around that entry site. And if that happens, we won't be able to stimulate these cells. You'll have less action potentials. And if I have less action potentials moving down this membrane, I'll have less signals. Those less action potentials that we release from these neurons, what is that going to do? Well, think about this. If the neurons aren't firing, your neurons are going to be like, yo, bro, we're super chill and just, hanging, bro. And so this can slow everything down. And so oftentimes this can present in a spectrum. We may see this as lethargy. It may progress to confusion, right? And sometimes it can even lead to severe depression. So it's definitely a kind of a degree or spectrum, I would say, of how these patients could potentially present. So this is one potential thing that I would think about with these patients. All right. The last one is they are arrhythmia prone. So stones, bones, thrones, groans, psychiatric overtones, and arrhythmia prone. The concept behind this one is that when patients have arrhythmias, again, it's calcium is moving into these myocytes during the plateau phase. So if you have lots of calcium, if you got lots of calcium out here in the extracellular space, it's going to easily flush into these cells super quick, right? When it flushes into these myocytes super quick, what's it going to do to the plateau phase? It's going to shorten it because it's going to be flushing in. And so what you'll notice here is that these patients tend to have a very shortened kind of like repolarization period. And that will do what? It'll change the QT interval. So again, I wanted you to remember here that as you do what? As you increase the calcium, you decrease the QT interval, which is again from here to here. So again, high calcium will lead to a decrease in the QT interval. Now, as you decrease the QT interval, is there any specific arrhythmias that you are at risk for? Not necessarily. And so that's why it's more of just an ECG finding that you want to be aware of. My friends, we went pretty hard on calcium, talking about the pathophys and the causes and the complications, and I think it's important because it's now going to set us up for an immediate success and understanding of the diagnostics and the treatment. So let's move into that. The next thing is, how do we really approach this? So if I get a patient who has a calcium less than 8.5, what do I do? Well, the first thing to do is make sure it's real. So we like to check what's called an ionized calcium. All that's essentially saying is calcium can come in two forms. A free form, which is the ionized form, it's bound to nothing. And then the bound form, it's usually bound to things like albumin most of the time. And so if I check an ionized, I'm only checking that free form. All right, so that's one thing. The second thing is I can check what's called corrected calcium. So in other words, I can take into consideration what it's bound to most often, which is albumin. And if I take into consideration maybe a patient has an albumin abnormality, and when I correct for it, if the calcium comes back normal, okay, then this is not even real. So if I check an ionized calcium and a corrected calcium and they come back normal, all right, in other words, between the 8.5 to 10.5, this is not real hypocalcemia. This is pseudo. There's probably something wrong with the albumin. What do I mean? Well, again, calcium comes in a free form and a bound form, which is calcium and albumin. So when you think about this formula per se, it's looking at the total calcium, which is both of these. All right. And so whenever you have a patient you're looking at their total calcium, you're trying to say, okay, it's a free and bound form. Well, really, if it's pseudo hypocalcemia, it's not going to affect the free form. It's really going to affect the bound form. And so when a patient has a decreased total calcium, there should be a decreased bound form. That's what causes pseudo hypocalcemia. Well, what would cause a decrease in the bound form? A decreased albumin, like hypoalbuminemia, which we can see in cirrhosis, where they don't produce albumin, or nephrotic syndrome, where they secrete or they lose albumin into the urine. Either way, if I have less of the albumin, I have less of the bound form, which drops my total calcium. So if I throw this into the equation, what their total calcium is, what their albumin is, this will figure it in to say, okay, the corrected calcium is actually normal or it is actually low. And that's the purpose of this. So if we do these things, and if we correct or we obtain the ionized, the question is how do I know which one to do? Ionized is better for inpatient. Corrected calcium is better for outpatient. But either way, if it comes back low, then this is real. All right. And then I got to get a PTH level, because then I need to know, is it PTH dependent or PTH independent? So if I get the PTH level and it's low, it's PTH dependent now. And so what I know is that this is driving the hypocalcemia. And this is usually hypoparathyroidism. If it comes back high, then it's none of those things. It's something to do with low vitamin D or calcium sequestration or that pseudo hypoparathyroidism. And so for those, I would get something like a phosphate and I get some vitamin D levels, right? Let me explain a little bit more again. If I look at the PTH and I'm really trying to get this, the low PTH, what it's telling me is I've cut out a chunk of the parathyroid, like a surgical reason of some sort, right? Or I had low magnesium and I'm not producing the PTH, that's driving the hypocalcemia. If the PTH is high, this isn't what's driving the hypocalcemia, something else is. So it's because the PTH receptors aren't responding on the bones and on the kidneys and the calcium staying low. Or because I have low vitamin D and I'm not absorbing enough calcium across the gut. Or I have CKD and I'm not activating vitamin D, or I'm having lots of phosphate that's sequestering the calcium and dropping the calcium. Either way, these things are leading to low calcium, which is telling the parathyroid gland, hey man, help me compensate and pump up the PTH. So in these diseases, it's a compensation, not the cause of the calcium. In this disease, it is the cause of the low calcium. So if we go back to this side of this limb of the algorithm, we say, okay, they have low PTH levels, it's hypoparathyroid. I just need to know, did they have neck surgery or some kind of parathyroidectomy, thyroidectomy? If they did, it's probably that. If they didn't, then I should check a magnesium level and see if it's low. If it's low, it's likely hypomagnesemia. Give them back magnesium. In this scenario, I got to figure out if it's CKD, vitamin D deficiency, or pseudo-hypoparathyroidism. Well, how the heck do I do that? Well, all right, if I check all of these things here, I know that the phosphate's going to help me in some way, shape, or form with CKD, and then this is going to help me in some way, shape, or form with the vitamin D deficiency. All right, let's check it. Well, if I get a high phosphate, a low 1 time of 25 dihydroxyvitamin D, this is less active vitamin D. Oh, well, if I don't have any effect of the PT, so let's say think pseudohypoparathyroidism. And pseudohypoparathyroidism, they're making PTH, but the PTH isn't hitting the receptor. Well, PTH for phosphate, what is it supposed to do? Reabsorb calcium, excrete phosphate. It can't do it. Phosphate goes up. Okay. CKD, we know the phosphate goes up, and we know it can't activate vitamin D. The other thing is with pseudohypoparathyroidism, it can't act on the proximal tubular cells, so it can't lead to the expression of alpha-1 hydroxylase, and it can't activate vitamin D. Oh, well then pseudohypoparathyroidism and CKD should both have this. All right, well then how do I differentiate them? Look at the renal function, right? Look at the renal function. This thing's going to be jacked up. So if you get a renal function panel and they're all jacked up, it's CKD. If it's normal, it's likely the pseudohypoparathyroidism, right? And in the other situation here, I really want to know that vitamin D deficiency, oftentimes due to decreased sun exposure or malabsorptive syndromes or things like that nature, it's really only this guy that's the problem, not this guy. So they'll have a low 25 hydroxy vitamin D, and that'll cause their vitamin D deficiency. So that's the difference here. And after you've done this, let's say that you've done all this and you're like, man, the PTH levels, I can't even depend on them, or there was an acute drop in the patient's calcium. Think about calcium sequestration, right? So think about, did they have seizures, crush injury? Did they have an acute kidney injury, elevated CK? It's rhabdo. Do they have non-Hodgkin's lymphoma, AML? They got chemo, they got elevated LDH, elevated uric acid, they got elevated phosphates, and then they got hypocalcemia. It's tumor lysis. Did they have epigastric pain, lipase 3 times the upper limit of normal? It's pancreatitis. Did they get massive blood transfusions? It's citrate excess. Those are the ways that I want you to think about this when approaching hypocalcemia. What about hypercalcemia? Again, same thing. Is it greater than 10.5? Okay, it is. Let's make sure. Let's check the ionized, make sure that the ionized actually is elevated. Let's check the corrected calcium for albumin. Why? Well, if hypocalcemia, I was looking for them having low bound form, and hypercalcemia, they would have to have high bound form. That means they would have to have high albumin. Oh, I should check this, even though that's less likely. All right, well, if I do that and the calcium and the ionized and the corrected calcium comes back normal, okay, then it could be pseudohypercalcemia. And I got an issue with the albumin, right? In that case, think about this. Again, it's free and there's bound. The bound is calcium and albumin. So when you look at the total calcium, you're looking at the bound form and the free form. And again, it can't affect the free form for it to be real. All right, for it to be pseudo, you can't affect the free form. You have to affect the bound form. So if I have an increase in the total calcium, I have to have an increase in the bound form for it to be pseudo. What's increasing the bound form? Albumin. So hyperalbuminemia. There's not many things that do this. Dehydration maybe, pregnancy potentially. But again, this is the only reason the patient would have this high albumin. The only way you could figure this out is to plug it into this equation. All right? Oftentimes we kind of look at this as every kind of one drop in albumin, you just multiply, you add 0.8. So usually for every kind of like one drop in this, you can just add 0.8 to whatever the calcium is and determine if it's high or if it's low. All right. In this situation, if I check the ionized of the corrected calcium for albumin and it comes back elevated, then I know, okay, this is real. And I got to check a PTH. I need to know if it's PTH dependent or PTH independent. If I check it and the PTH comes back high, that's hyperparathyroidism. But if it comes back low, it's anything with the vitamin D that's elevated, the PTHRP that's elevated, the lytic lesions or the increased bone turnover, and I got to get a bunch of tests to think about this. Again, let's talk about this. You have to remember that when you're talking about high PTH, this is driving their hypercalcemia because their parathyroid in primary is pumping out PTH, Or in tertiary, they have CKD that's leading to high phosphates, low active vitamin D, less calcium. Over time, the parathyroids gain the capacity to overproduce the PTH, and eventually that drives up the calcium. As compared to the low PTH states, it's something else that's causing their hypercalcemia, and the PTH is a reflection of that hypercalcemia. In other words, if they have high vitamin D, high PTHRP, or high bone turnover, all of these things lead to high calcium, and that high calcium shuts down the parathyroid from producing PTH. Now, if we look at the hyperparathyroidism, your job is to decide, is it primary or is it tertiary? And we'll add in a small little caveat there. For this, I like to look at the urine calcium and the phosphate. Now, in patients who have primary hyperparathyroidism, what we'll find is that they'll have a very high urine calcium, and their phosphate in the bloodstream will be low. Think about that. If PTH is high in primary, it's going to reabsorb calcium and excrete phosphate. It's going to trash the phosphate. It's the phosphate trashing hormone. So this right here suggests that a patient has what's called primary hyperparathyroidism. Now, if I check the urine calcium and it comes back low and they have a low phosphate, this means something very, very interesting. So if a patient has high PTH but they have a low urine calcium, always think about this disease on your boards. It's called familial hypocalciuric hypercalcemia. It's a weird defect in their calcium sensitive receptor. And the last scenario here is tertiary. So their urine calcium will be high, but their phosphate is what's really high. Because again, in this scenario, the kidneys are working and responding to the PTH to trash the phosphate. In this one, the kidneys are diseased. They can't respond to the PTH to trash the phosphate, and the high phosphate is actually what drives these patients to have high PTH levels, right? And so this is tertiary hyperparathyroidism. For these, we have to look at all of these. Okay, well, let's think about this. If I have high PTHRP, oh, boom, those squamous cell carcinomas of the lungs, the kidney, the breast, done. That's a type of hypercalcemia malignancy, boom. If I check the 1,25 dihydroxyvitamin D and it's super elevated, boom, that's the granulomatous diseases like sarcoidosis or potentially Hodgkin's lymphoma. But if those are relatively normal or they're not super concerning, that's when I got to think about potentially lytic lesions or have elevated bone turnover. So that's when we'll get like a skeletal survey. We may do a bunch of different x-rays. We may do potentially CT scans, whatever it may be, and you'll find all of these lytic lesions. When you see these lytic lesions, that's when you want to check this thing called the alkaline phosphatase. It kind of determines a lot of bone turnover per se. And we see this a lot in cancer. So when there's lots of cancers, they can really chew up the bone and we'll see their alk phosphate levels elevate. Not so much in multiple myeloma. So if the alk phos is relatively normal, it's probably multiple myeloma. But if the alk phos is super elevated, you should definitely be on the lookout for a bone metastasis. All right? This is the way that I want you to think about the bone turnover, the elevated vitamin D, the elevated PTHRP, and the elevated PTH, which could be primary, tertiary. And I threw in this little nugget here that you may see on the exam. Whenever you see low urine calcium, high PTH, and high calcium, think about FHH. Now, what about the calcium's other reasons why hypercalcemia? These can sometimes be on the board exams. I would think about some miscellaneous causes like milk alkali syndrome. Oftentimes, these patients present with metabolic alkalosis, hypercalcemia, and AKI. Thiazide diuretics can also cause hypercalcemia because they help to actually play a role in reabsorbing calcium across the distal tubule. And lastly, immobilization can also be considered if a patient's history fits that scenario. But I think this gives you everything you need to know for hypercalcemia. Let's now move on to how do we treat this stuff? Well, when a patient's got low calcium, you just give them calcium, right? Pretty much in the sense, you can give them oral or IV. It's just the indications depend on which one you give. For example, if the calcium's not like super scary low, for example, it's like greater than 7.5 but less than 8.5, I would feel comfortable not rapidly having to increase their calcium. I give them oral calcium, right? And the whole point is I don't want to get these neuromuscular irritability. I don't want them to get arrhythmias. That's the reason why. If I have to give them IV calcium, I'm giving it because their calcium is less than 7.5, or they're having symptoms like neuromuscular irritability, or their QT interval is getting super prolonged. That's when I'll give IV calcium gluconate or chloride. All right. The other scenario is I can give vitamin D. Now, vitamin D is also known as calcitriol, but this is the active form. This right here is 125 dihydroxyvitamin D. The indications to give this is pretty much any scenario where the patient has decreased active vitamin D. Watch this: secondary hyperparathyroidism, hypoparathyroidism, and pseudo-hypoparathyroidism. That's a lot of stuff. Let's explain this for a little bit, because the purpose of this is to, again, prevent them from developing recurrent hypocalcemia. Because if you give them vitamin D, you're treating their deficiency in vitamin D, and you'll prevent them from developing recurrent hypocalcemia over time. So watch this. In patients who are giving the oral calcium and vitamin D to prevent recurrent hypocalcemia and hypoparathyroidism, they have low PTH. They directly drop the calcium via the bone and reabsorption across the kidney, but they also lead to less active vitamin D. If I give them vitamin D and I give them calcium, I fix these two issues. Some would say, why don't you just give them PTH? We don't necessarily give patients PTH who have hypoparathyroidism. The other thing here is, what if they have secondary hyperparathyroidism or pseudo-hypoparathyroidism? Well, again, in these particular scenarios where they have CKD, vitamin D deficiency, which is the secondary type, they have low vitamin D. That again is going to lead to low calcium. So if I give them vitamin D, I will also give them calcium. I'm going to fix the issues that they have and reduce recurrent hypocalcemia. And then lastly, if they have pseudo-hypoparathyroidism, they're releasing too much PTH. Too much PTH, but again, they're not getting effect at the bones. The osteoclasts aren't responding, and they're not reabsorbing the calcium, resorbing the calcium. You're not getting an effect at the kidney, so you're not activating the vitamin D, and you're getting less active vitamin D, as well as less calcium reabsorption. So if I give them calcium and I give them vitamin D, I'm fixing their problem. All right. If you could come up with a way to reduce the receptor resistance, cool. So again, you may think, oh, in this scenario, give PTH. No, we actually give them vitamin D and calcium. In this scenario, vitamin D, calcium. In this scenario, vitamin D, calcium. Now, the only time where I'll give another drug like magnesium is if they truly have hypomagnesemia, because if you give them magnesium, it'll restore their PTH production and they'll be able to prevent from developing recurrent hypocalcemia. The next situation is phosphate binders. This is really good in situations where patients are having significant elevated levels of phosphate chronically, not so much acutely. So I wouldn't really say that this is the best in scenarios of high acute phosphate levels like rhabdo or tumor lysis syndrome, things like that. I'd say this is best in CKD. So in CKD, the reason why we do this is because they have high phosphate levels. Their GFR is dropping, they're having high phosphates, and that's binding to the calcium and it's sequestering it and dropping the free calcium. So if I give them a phosphate binder and they absorb, they ingest this, anything that they eat in their diet that has phosphates, this puppy is going to bind to that phosphate, and it's going to cause less phosphate to get absorbed. If less phosphate's absorbed, less phosphate is going to bind to the calcium and cause the calcium levels over time, the free calcium, to go up. And again, the whole point of that is that the phosphates will get lost into the stool. So this is a really good indication in patients who have CKD, which is that secondary hyperparathyroidism. All right? So hypoparathyroidism, calcium, vitamin D. Pseudo-hypoparathyroidism, calcium, vitamin D. Vitamin D deficiency, calcium, vitamin D. CKD, vitamin D, calcium, and phosphate binders if they have hyperphosphatemia. Lastly, we can consider thiazide diuretics. We only really do this in patients who have really significant issues with their PTH, such as hypoparathyroidism or pseudo-hypoparathyroidism that does not respond to calcium and vitamin D. The concept behind this is that if we're giving this, what it does is when you give thiazide diuretics, you're inhibiting the sodium chloride reabsorption of the distal tubule. And so what happens is when you inhibit this, you get less sodium that's actually going to be present inside of the cell. When you have less sodium present inside the cell, now the sodium-calcium exchangers become activated because sodium easily rushes into the cell. Because if it's lower here, it can go down its concentration gradient. When sodium comes in, guess who comes out? Calcium. And calcium will flush out. If calcium flushes out here, what happens to the calcium inside the cell now? That is going to drop. And if calcium drops, guess what? Then calcium in the tubular lumen is going to say, oh, calcium in here is really low. I'm going to start flushing into this cell. And eventually that calcium will get reabsorbed. So you get lots of calcium reabsorption with thiazide diuretics, which leads to hypercalcemia. And so it may help to prevent that recurrent hypercalcemia in patients who aren't responding to the traditional therapies of calcium and vitamin D. Now, this may seem like a lot. Let's do this in an approach kind of algorithmic manner. If a patient has a calcium greater than 7.5, that's safe. I'm not too worried. I'll go oral. If it's less than 7.5 or they're developing neuromuscular irritability, QT changes, IV. Regardless of which one I'm giving them, I then need to treat the underlying cause. If it is secondary hyperparathyroidism, if it is hypoparathyroidism or pseudo-hypoparathyroidism, all of these situations respond well to giving them oral calcium and vitamin D. If they do have refractory pseudo-hypoparathyroidism and hypoparathyroidism and they're not responding to the calcium and vitamin D, that's when I would consider thiazide diuretics, especially if the calcium in their urine is high. If a patient has hypomagnesemia, give them magnesium. And lastly, if they have high phosphate levels in CKD, add on a phosphate binder like sevelamer, calcium carbonate, or calcium acetate. All right, what about hypercalcemia? Believe it or not, the most common manifestation of hypercalcemia is oftentimes dehydration due to excessive polyuria. When a patient has excessive polyuria, they get super volume depleted. Guess what we want to give them? Acutely. So when a patient who has acute hypercalcemia and it's severe, how do I define severe? I would say in this situation, the patient has to have a calcium greater than 14. And if they're symptomatic, that's even worse. In this situation, they're likely severely volume depleted. I need to give them heavy amounts of IV fluids. So I'm going to give them normal saline. The purpose of this is to rapidly decrease their calcium and also improve their volume status. So think about this. In a patient who has hypercalcemia, it causes nephrogenic DI, which leads to polyuria. I then can see that these patients would lose a lot of blood volume, become significantly dehydrated. I'm going to give them the IV fluids to replace their vasculature and pump up their blood volume. That's the design of giving the IV fluids. But it also will, in the process, rapidly decrease their calcium. The only time we used to back in the day, but this is no longer recommended, is they used to use loop diuretics and IV fluids like normal saline. We don't recommend that anymore. The only time that you'll use diuretics if the patient is getting IV fluids, and because of the excessive amounts of IV fluids, because you have to give these patients sometimes 3 to 6 liters of IV fluids to rapidly replace their volume losses and help drop their calcium. If they start to develop pulmonary edema and as well as excessive volume overload with respect to their legs, they're developing a lot of swelling and hypertension, then I would consider giving the patient diuretics only then. After you've given them a good amount of fluids to replace their volume losses and help to drop their calcium, the next drug that you want to give is calcitonin. The reason why you want to give calcitonin is this has a very quick and acute onset. And what it's going to do is it's going to go at the bone and it's going to shut down these osteoclasts. If it inhibits the osteoclast, it's going to shut down the bone breakdown. If I shut down the bone breakdown, I'm going to reduce the lytic lesions and all the bone disease processes, and I'm going to help to decrease the calcium, because if they're not breaking down bone, they're not liberating calcium. Again, calcitonin is the first line agent because it has the quickest onset, but its duration is not as long. So then, after I've given them IV fluids and I've given them the calcitonin, if I need a drug because I suspect that they have hypercalcemia of malignancy, which is oftentimes the most common cause of severe hypercalcemia, that's when I would make a decision to give one of the two drugs next, a bisphosphonate or a denosumab. Bisphosphonates are good to give in the acute management, especially when the calcium is greater than 14, they're symptomatic, but more specifically, you want long-term control because you think that they have hypercalcemia malignancy. The purpose of this is to also help to decrease the calcium, but it's not going to be rapid. It's more of preventing bone disease and preventing recurrence of hypercalcemia and hypercalcemia malignancy. Again, bisphosphonates and denosumab, just through different mechanisms, are going to shut down the osteoclast, decrease bone breakdown, decrease bone disease like osteitis, cystic fibrosis, osteoporosis, pathological fractures, as well as they'll decrease the calcium. The only difference between these and calcitonin is that bisphosphonates have a longer onset. So they're going to have a longer onset. You're going to use these more likely continuously in the patient, but you have to be careful because they're somewhat contraindicated in severe kidney disease. So if the patient has severe kidney disease, you may want to go the route of denosumab, who also has a long onset, but it's a little bit more safe in patients who have underlying kidney disease. So this is what you're going to throw on: IV fluids, calcitonin, and then one of the other drugs can be added on for long-term control, not as much acute control, and that's the bisphosphonates and denosumab. If you've done all of these things, you started a patient on IV fluids, you've given them calcitonin, started them on a bisphosphonate, and their calcium remains elevated despite these measures, that's when I would go the route of putting a patient on hemodialysis. All right. The next thing is, after you've treated the acute problem, which is the severe hypercalcemia, then you need to treat the underlying cause. And so sometimes we'll then move to the next thing, which is, okay, what was really driving this? If a patient has what's called hyperparathyroidism, whether it's primary or tertiary, and they're not a good surgical candidate, all right? In other words, if they have parathyroids that are really big because of primary problem, so an adenoma, or they have parathyroids that are large because of the CKD that's caused them to undergo hyperplasia, we would want to cut that out. But if we can't cut that out, let's suppress those cells from releasing PTH the best that we can. So that's when we use calcium mimetics like cinacalcet. What's really interesting about this is that this can help to prevent recurrent hypercalcemia in hyperparathyroidism. How these work is really interesting. Calcium binds to a calcium-sensitive receptor, and that's supposed to say, hey, if calcium's high, shut down PTH. Well, if I give a drug that acts like calcium, it can do the same thing. And it'll bind to the calcium-sensitive receptor and say, hey, calcium's kind of high, shut down the PTH synthesis. And this can potentially help in patients with hyperparathyroidism. It can prevent hypercalcemia. If the patient is a good candidate for surgery, and they have lots of bone disease, lots of kidney disease, this is where I would potentially say we should do a parathyroidectomy. We should cut out the parathyroid glands. And after we cut them out, we want to, in case they need to have the parathyroid, at least some degree of it having a basal release, or if we have to go back in and cut something out, let's not keep it in the neck. Oftentimes what they'll do is they'll implant that parathyroid gland into the forearm. So it's an easier site of access if they have to remove it later. All right. Lastly, if a patient has hypercalcemia due to some type of lymphoma or sarcoidosis, corticosteroids are actually preferred. And it's because these help to suppress this alpha-1 hydroxylase, which leads to less active vitamin D and then less calcium. So again, giving steroids will suppress this alpha-1 hydroxylase. And that's the concept here to remember. Now, I know this is a lot. How do we do this? How am I supposed to remember this? Here's what I want you to remember. If it's high and they're symptomatic, this is not good. You got to get acute management ongoing now. Get them some fluids, get them calcitonin, and get bisphosphonates or denosumab on board. If the calcium is less than 12, so they're likely to be less severe, they're asymptomatic, in this situation, you can take your time and treat the underlying cause. If the patient has been treated with IV fluids, calcitonin, bisphosphonates, and they're not getting any better, that's when you go to hemodialysis. But if they are experiencing improvement, then we fix the acute issue. Now we got to prevent them from developing recurrent hypercalcemia. How do we do that? We ask ourselves the question, is it hypercalcemia malignancy? Oh, it is? Keep going with these. Is it some type of primary or tertiary? Can we cut out the parathyroid, or can we suppress the parathyroid? Calcit mimetics like cinacalcet, or a parathyroidectomy, depending on their surgical candidacy. And then lastly, is it, in this scenario, sarcoidosis or lymphoma, corticosteroids? So this is the way that we acutely treat them, determine if they need rigorous hemodialysis, or if we can just go straight to treating the underlying cause. Ninja Nerds, I know this was a lot, but I really hope it made sense. I hope that you guys enjoyed it. And I love you. I thank you guys. And as always, until next time.